Okay, so what we're going to look at today is the objectives for the seminar today are really, a large portion of what we're going to do the first 20 minutes or so is looking at pressure ulcer staging. We're looking to obviously look at the clinical reimbursement portion of this, but to get this correct on many sides, including the payment, the expense side, everything, we need to ensure that our ulcers are being staged appropriately and that they're consistent throughout the facility. The other thing, we're going to look at how to measure wounds briefly with CMS. We'll discuss the importance of an interdisciplinary collaboration for wound differentiation in your facilities. As I mentioned, a pretty in-depth view of Section M and coding that correctly. The impact of how it affects RUG 3 and RUG 4. As many of you should well know, that Medicare adapted the RUG 4 system last October, and RUG 3 is still alive and well in many states across the country right now for those of you that are on a case mix reimbursement for your Medicaid. So that's something that I think we're starting to see across the country, that more and more states are looking to adapt RUG 4, and I do anticipate in the next year or two that most states will be over to RUG 4 completely and out of the RUG 3 world. A few other things we'll look at towards the end of this is the effects of wound care and appropriate documentation related to quality measures, and as well as the 5-star reporting. And I'll give you a bit of an update towards the end of the webinar about what's going on with 5-star. The National Quality Forum and CMS have put out the latest updated endorsed measures, and there are a couple of them that are going to affect wound care directly, short-term stays and long-term. And then we'll wrap up with the expense management side of it as well. So anyway, so as we roll through here, this Section M and the MDS 3.0, skin conditions, it was a sweeping change when the MDS 3.0 came out. And if Deb, we can get that slide to advance. That'd be great. There we go. Okay. One of the biggest changes really was that the MDS 3.0 added an element of risk assessment, which we did not have with the MDS 2.0. And some of the other changes were changes to staging, that there was no more reverse staging. Those of you who were around in the MDS 2.0 world, it was really one of the only documents out there in long-term care that allowed us to backstage. And that's no longer the case. The MDS also now tracks the deepest pressure ulcers, worsening pressure ulcers, and it separated out items for unstageable and SDTI, the suspected deep tissue injury pressure ulcers. And that caused a lot of confusion when the NPUAP updated their standards in 2007. They were finding a lot of miscoding out there as to what got coded under SDTI versus what was coded as possibly a stage 2 or unstageable. So one thing I do want to say, I did see the poll, and it looks like we've got a lot of nurses on here, and I did see some administration as well. The slides for about the next 15-20 minutes are not going to be for the faint at heart. There are some pretty crude slides in here. I just kind of want to forewarn you. And we certainly talked about whether we were going to keep the slide active or not, and we actually ended up deciding that we're going to keep the slides in here because to show appropriate staging, we really want to make sure that we're able to show you a visual of that. And the other thing just to note is these pictures and many of these slides came right out of the CMS training slides. This presentation will be available for you as well. But if you're looking for more information, and this is an abbreviated version, but you can also find the full Section M staging on the CMS website under the training slides for the MDS 3.0. All right, so a few other changes that happened is there's now the pressure ulcer that are present upon admission and reentry, which is very, very important for you to establish when you're doing your MDS, especially as we're coming into quality measures in 5-star and other initiatives like Pay-for-Performance, which I'll talk about briefly at the end of the webinar also. It's going to be very important that you're not taking ownership of these pressure ulcers if it wasn't something that happened in your facility and it was done prior to admission. Also now tracks the date of the oldest stage 2 pressure ulcer, that the dimensions are now tracked right on the MDS in centimeters. And there's another area for looking at type of tissue, the most extensive type of tissue, and we'll certainly get into that as well. So one of the things is first and foremost taking a step back and looking at your organizational assessment. and looking at your organization and how does your whole how does your whole wound process work within your facility. And a few things you need to look at are the tie-ins with your clinical, as well as the administration, as well as your policies and procedures. Oh, Deb, looks like I finally have control over here. It's fantastic. So, okay. Oh, lost it again. So anyway, this slide you're looking at is the clinical administrative interface. And as we progress through, you're going to see some of the areas you need to focus in on are, what data is collected, how does it flow, is there consistency within your facilities of who's documenting and who's tracking what. Okay, so that's something you just want to make sure that you're looking at. How's it documented? Do you track it electronically? Do you do it on paper? Do you use a consistent tool? Are your policies updated in your guidelines? Do you have a process for pressure ulcer risk? And many facilities use some of the more popular ones like the Braden and Norton, that type of thing. And again, you just want to make sure that you're consistent with that. You've got a process for developing and implementing a care plan for at-risk residents as well. Now if the MDS is able to identify that, you want to make sure that you've got that in there and appropriately care planned. So the clinical skills needed really are that your staff need to understand what the risk factors are, what the risk assessment is, the new pressure ulcer staging, understanding how to measure appropriately, and then identifying wounds, be able to differentiate between what's a pressure ulcer and what may be SDTI or maybe a blister caused by something else. So that's something, again, we'll certainly look at. So as I mentioned earlier, with the rollout of the MDS 3.0 last October, CMS had finally taken the NP-UAP guidelines, guidelines from 2007, and that was all incorporated into the MDS 3.0. And primarily, a pressure ulcer is a localized injury to skin and/or underlying tissue that is usually over a bony prominence, but not always. And that's something you definitely need to keep in mind. You may have a pressure ulcer that was caused, let's say, from a splint that's halfway up the back of the calf. Not necessarily over a bony prominence, but still remains a pressure area. Okay, I think I've officially got controls now. Fantastic. So, all right. So first, we're just going to look at briefly the determination of pressure ulcer risk. And those of you that do the MDS on a daily basis know that there's an area on the MDS where we're going to capture that now, whether we identify people as being at risk. And some of the risk factors are immobility, decreased functional ability, many comorbid conditions you need to be looking at, end-stage renal disease, thyroid issues, diabetes, just for a few examples. Many medications as well, and steroids are a good example of what may put somebody at more risk. Impaired, diffuse, or localized blood flow. And certainly resident refusal of care and treatment, which is something else you need to have well documented. If a resident's refusing to be refusing incontinence care after an incontinent episode, that's certainly going to add an additional risk factor that you need to be very aware of. And some other cognitive impairment, exposure of skin to urinary and fecal incontinence, undernutrition, malnutrition, or hydration deficits. Certainly a major factor is healed pressure ulcers that have closed. They may be healed now, but the skin, from most of the standards, gets to about 80% of its normal capacity. So anybody, that's very important to be able to identify, if you see scars that are over bony prominences for a resident who's new to you, to make sure that you're looking at that. Okay, so this is just a brief picture here, and this just is this evidence of a risk factor, and yes, it is. This actually, you're going to see on the next slide, and this is where the weak stomachs may want to just turn the head to the left or right very quickly, but this actually started as a stage 4 pressure ulcer, and this is where it's at now as far as being healed 3 months later. But that person is always going to have this risk factor that they had a wound there. Okay, so as I mentioned before, in M100 there's the determination of the pressure ulcer risk, and there's multiple ways to do this, and CMS with the MDS is tracking how you're doing this. First, the number one factor that's connected here is, like I mentioned, either having an ulcer already, or scars over bony prominences, or non-removable dressings and devices. There's certainly your formal assessment tool, And as I mentioned, Braden and Norton are what we see most commonly. There are some other tools out there. I've seen some folks develop their own tools. And then the clinical assessment of the resident is certainly very important as well. You know, they may not have an active ulcer, or there may be that they weren't screened as being at risk under the Braden and Norton, but some other clinical assessments driven by the nursing staff would deem them as being at risk. All right, so here's some other risk factors too. Non-removable devices for sure. Could be a dressing or it could be a cast. Existing pressure ulcer, of course, and then a healed pressure ulcer. And here's just a couple of links of a couple of the formal assessment tools that are out there that I mentioned, and the clinical assessment as well. And you know, CMS also they're supportive of using mnemonics that will help you out. And one example that CMS specifically has given to us in the RAI manual is the HALT. And the HALT method is simply just going through and looking, is there a history of the pressure ulcer or patient events that may cause it, such as I mentioned, immobility, decreased functional ability. The A, looking at associated diagnoses and comorbidities, advanced aging, medications, other disease processes. Looking at the skin, which is obviously very important, you know, to do a full head-to-body assessment on every new admission. And most facilities, their policy is to do a weekly wound assessment, head to toe, and that's something that you want to make sure you've got instituted and have that documentation supporting in your facilities. And then D, touching the skin. And that's one I think folks miss quite often, and especially when you're dealing with things like SDTI and you're trying to assess damage, you know, that's something touching the skin and noticing changes in temperature may be another key indicator to help you out as far as coding. So this simply on M150 of the MDS is just looking at pressure ulcer risk, and is it a yes or a no? Okay, so unhealed pressure ulcers in 210, and that's just simply on the MDS. They want you to identify, does the resident have one or more unhealed pressure ulcers at stage 1 or higher? Then we have the current number, and that's where we dig into I guess the meat and potatoes of Section M, is when we're looking at M300, and we've got to actually start listing out what we've got for ulcers there. There is some information available on the MPUAP website, which is listed here. You know, to get more information, there's some educational tools that are available. And just to reiterate one last time, CMS has adopted these adapted these definitions, or adopted either way, but this is what we're using now. You know, so the MDS is much more consistent with coding as it goes on. So before you do any type of measurement, assessment, anything like that, there's a few things you need to keep in mind when we're assessing wounds. You know, again, we want to determine the deepest stage of each pressure ulcer. You want to identify appropriately unstageable pressure ulcers, and I mentioned very important present upon admission, as this is going to affect, as I mentioned, 5-star and your pay-for-performance when that comes into effect. Okay. All right, so again, we do not reverse stage. You know, you need to consider the current and historical levels of tissue involvement. And one other thing, just throw here, you know, be careful not to code lesions. Be able to identify that appropriately. And we'll have some examples of that coming up. So the first part is, you know, looking at a stage 1 pressure ulcer. And you can certainly see the definition here of the stage 1. And what it's looking at, it's the intact skin with non-blanchable redness of a localized area, usually over a bony prominence. It may be a little more difficult to detect in residents with darkly pigmented skin. So something else that may just require a little more assessing. In dark skin tones, it may appear with persistent blue or purple hues. Okay, and this you're going to see this slide come up a few times, but you know, just again, you just want to make sure you conduct a full head-to-toe body skin assessment, focusing specifically on bony prominences or other pressure-bearing areas. So some of the examples are the sacrum, the heels, the buttocks, and ankles, which is where we commonly find pressure ulcers. You want to check any red areas for ability to blanch. Right, and some other things you want to look at for the surrounding skin is it painful? Is the surrounding skin soft in comparison to the rest of it? Is it firm? Is it warmer or cooler than the rest? Is there a change in color with the surrounding skin? Again, that may be indicative of more damage underneath more than what's exposed at the surface level. Okay, so with any staging, it should certainly be holistic. You don't just want to rely on one descriptor. You want to look at the whole process. And I'm just going to kind of move along here. So we're going to address some of these other ones as we come into the following slides. But this here is just a brief example of a couple of stage 1s, right, where it's non-blanchable redness of a localized area. And it's just a brief example. I know I've got you all muted and we're holding questions until the end of the presentation. But this is just a brief example of, is this a pressure ulcer? And this most likely is not. The picture, it's a little hard to get full focus on this, but what this is more irritation and redness that you're seeing here, likely causing incontinence or some exposure to moisture. All right, so going into a stage 2 pressure ulcer. Stage 2 consists of partial thickness, loss of dermis, and presents as a shallow open ulcer. It could be red or pink wound bed. And one thing to just note, that there will be no presence of slough in a stage 2, even a small amount. If you're starting to see slough, then we're likely talking more about a stage 3 or higher, and we'll get into that. Okay, it may also present as an open or ruptured blister, and this is something else you need to be watching out for. To make sure that this blister is, you've identified it as being from pressure and not from something else. Sometimes they can get blisters just from incontinence and urine contact with the skin. I've seen it where briefs are on too tight, and that causes some blistering too, more up around the pelvic region. So stage 2 generally lacks the surrounding characteristics found with deep tissue injury, and this is certainly where there's been some confusion over the last few years when we're looking at blisters. Generally, a blood-filled blister related primarily to pressure, or more likely than serous-filled blisters. The blood-filled are more likely to be associated with SDTI, where a serous-filled blister is going to be more likely a stage 2. Right, and something else to be cautious of, do not code skin tears, tape burns, dermatitis, maceration, excoriation, or SDTI in this area of the MDS. All right, so the MDS looks for the number of stage 2s, the number of stage 2 pressure ulcers upon admission, re-entry, the date of the oldest stage 2 pressure ulcer, and the guidance via the RAI manual for this is, for into admission, is to try to go back and assess as best you can if you can come up with the date when this stage 2 pressure ulcer started. If you don't know, then it's okay to put dashes in there. CMS advises us not to overuse dashes, but sometimes you have no historical data, you don't know where the ulcer came from, it was just there, and at that point you can't necessarily assign a date to it if you're not sure. Okay, this here is a pressure ulcer blister, and as we mentioned earlier, this is a serous blister, and more likely to be related to pressure versus a blood-filled blister like the one that you're seeing now that is probably more related to SDTI. All right, now this one is burns. This poor guy got stuck with the hot potato. This is very clear that this one is blisters. It's on the hand. As I mentioned earlier, you may have blisters in other areas that may be a little harder to differentiate whether they're pressure or not. Okay, so just to briefly look at stage 3 and stage 4 pressure ulcers. Again, this is making sure you perform your full head to body, head to toe assessment. Okay, stage 3 is full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. And this is another area you need to just be cautious with. I've seen some inaccurate coding because somebody viewed slough as being subcutaneous fat tissue, and there are certainly some similarities, and you need to be able to, when you're assessing, differentiate between the two and ensure that it's truly subcutaneous fat that you're looking at versus slough. Okay? And for a stage 3, it may be present, but it does not obscure the depth of the tissue loss. And that's one key note there for stage 3. May have some undermining and tunneling as well. Right, so again, for the MDS, you need to identify the number of stage 3 pressure ulcers, how many were present upon admission and re-entry, All right, stage 4 is a full thickness tissue loss with exposed bone, tendon, or muscle. Slough or eschar may also be present on some parts of the wound bed. It often includes undermining and tunneling with a stage 4. And depths may vary. You don't just want to judge it because of the depth. You may have one perhaps on the back of the ear that was related to oxygen tubing, and that does not require very much depth to be coded as a stage 4 ulcer. So that's what you need to be looking at. Is there a full thickness of tissue loss, exposing bone, tendon, or muscle? All right, and just like the other areas, then you need to code number of stage 4s and number present upon admission and reentry. Okay, unstageable pressure ulcers. And just a few things to differentiate here is, this was certainly a sweeping change with the MDS 3.0 that we're able to separate these out, where with the 2.0 we were lumping our unstageable ulcers in under stage 4s most of the time. Right? So just kind of go through this. Some of why you may have unstageables. First and foremost, it may be a non-removable device. It may be a cast. Now, for you to code this, you do need to know that there is some kind of ulcer underneath the cast. Obviously you don't want to just be coding everybody as they're at risk if they have it, but if there's no known ulcer, then we certainly wouldn't code that until after we know there's an ulcer there, and it may get recasted or something along that line. Okay, the second one is non-removable dressings, and we've seen a lot more of these. I think with the introduction of wound vacs becoming more mainstream over the last several years, we've got to keep that dressing in place for several days. At the time coming into the MDS, we may not have appropriate documentation, or that dressing may be on for an extended period of time. And then the other unstageable area would be related to slough or eschar. And this would be, we were unable to stage it because the entire wound bed is covered in slough or eschar. There's a full thickness tissue loss. The base of the ulcer covered with slough, it could be yellow, tan, gray, green, or brown. Eschar is generally tan, brown, or black in the wound bed. And then SDTI, this is where I do believe we've certainly had some more confusion than ever over the last several years. And it is a little difficult to differentiate sometimes, and you just need to be consistent with your documentation. The localized area is generally discolored. It's darker than the surrounding tissue. The skin is intact. It's generally related to damage of underlying soft tissue from pressure or shear. Area of discoloration may be preceded by tissue that is painful, firm, mushy, boggy, warmer, or cooler. And that's why I mentioned earlier on, it's very important to make sure that you're touching the surrounding area rather than just doing the visual. Okay, so looking at this, quality health care begins with prevention and risk assessment. I think we all know that. And as we start coming into some of the other initiatives with CMS like Pay-for-Performance, it's only going to become much, much more important that you are identifying wounds before they happen. Somebody with risk, or making sure that when we do have an ulcer, that we're keeping it from getting worse. Right? And care planning, again, begins with prevention. And appropriate care planning is always essential. I guess the comment I'd like to make about care planning is making sure your staff are aware of the care plans as well. That's some of the issues. I've seen some very, very well-written care plans, and the staff don't utilize them. And that's something you just need to look at from an internal process standpoint. Have you gone too far with your care planning process, and now you've got 25 care plans sitting in a medical record that really takes somebody 8 hours just to get through the care plan. So you just got to look, are you able to condense your care plans, identify really what the key factors are, what the key problem is, the goals, and the intervention, so it's a user-friendly tool for all staff. Okay, as always, you want to clearly document your assessments and findings, track and document appropriate wound care planning. The deep tissue injuries can indicate very severe damage underneath the skin. Okay, so for all three of these areas, again, you're just going to code each type of pressure ulcer, code the number of each type of pressure ulcer present upon admission re-entry. Do not code lesions in this area if it's related to excuse me, Do not code when a lesion related to pressure presents as an intact blister and the surrounding or adjacent soft tissue does not have the characteristics of SCTI. So again, you just need to be very careful to differentiate between those. That may be more likely to be coded as a stage 2. So just to briefly go through the dimensions here, this is just another area that was not on the MDS 2.0, which is, as you well know, on the MDS 3.0, where they're looking for dimensions for your stage 3 and stage 4 pressure ulcers or your unstageable. So you need to measure every stage 3, 4, and unstageable related to SLOP or eschar to determine which one is the largest. And you're always going length by width, and you want to make sure that you're doing this in centimeters, and that's how that's captured on the MDS, again in centimeters. All right, so you can see here depth is also captured there, so length, width, and depth are all there. Although these won't necessarily directly affect your quality measure portion when we're looking at worsening of ulcers, this certainly is something internally that surveyors will be able to track the progression of your wounds. You as a facility will be able to better track sizes, if it got larger, smaller, if the depth got deeper. And just a couple of techniques. This is again from the REI manual that they recommend using a moistened sterile cotton-tipped applicator to check depth. Place it at the deepest aspect of the wound and measure the distance up to the skin level. Okay, so M700 looks at the most severe tissue type of any pressure ulcer. And this is where we're now tracking on the MDS again, the types. So you've got epithelial tissue is the first one, and that will be presence of new skin growing in a superficial ulcer. It can be light pink and shiny. The granulation tissue is pink or red tissue with shiny, moist, granular appearance. A SLOP, yellow or white tissue that adheres to the ulcer bed in strings or thick clumps or is mucousy. Then you've got necrotic tissue, which is eschar, and that may be black, brown, or tan tissue that adheres firmly to the wound bed or ulcer edges, maybe softer or harder than the surrounding skin. Okay. And M800, this is the one that's going to directly affect the quality measures that are going into effect, in which your quality measures will tie into the PayforPerformance, and I'll be getting into that momentarily. So this one is very important to be tracking. You can complete this only if it's not the first assessment, which obviously makes sense. It's a point of comparison from the previous MDS. It looks back to the prior assessment reference date, the most recent MDS. Okay. You want to enter the number of pressure ulcers that were not present or were at a lesser stage on the prior assessments. Okay. So again, this is entering the number of pressure ulcers that were not present or at a lesser stage. You'll see that it doesn't give us guidance, if the wound got a little bit bigger, maybe 1 centimeter longer in length or width. Okay, and you're going to code 0 if none of them have worsened or there are no more pressure ulcers present. So again, M800 is really tracking the progression through types of ulcers, not necessarily the size of an existing ulcer. That's something you definitely internally want to track. M900 looks at healed pressure ulcers, okay, and how many at each stage had healed since your prior assessment. And there's a couple other things here before, and when we'll wrap up the MDS portion of this, is M1040 and M1200 looking at other ulcers, wounds, and skin problems. Okay. And this is important, very important to always review the medical record, talk to your staff, see what's going on here. Do you utilize flow sheets? As I mentioned earlier, they're consistent. Speak directly to your staff and treatment nurse. Sometimes it's a little more challenging in facilities that, you've got different people measuring wounds. And that's something I generally recommend. You do get some kind of wound team together if you don't have one. Where at least once a week you've got a consistent measurement, just to ensure, again, that you're not inappropriately staging or sizing wounds simply because it was 2 different clinicians. And we do all look at it a little bit differently. So you just want to make sure, again, that you've got those systems in place to ensure you've got accurate documentation there. Okay, so a few other things that are separated out are diabetic foot ulcers, and here's a picture of one. You've also got open lesions other than ulcers, rashes, cuts. And again, this is something you want to make sure you assess. I have seen some lesions inappropriately coded as ulcers. Sometimes it's a matter of thinking it's a blister versus a lesion, so you've got to be able to differentiate those. This is just an example of a surgical wound, and this example is actually a failed flap. This was somebody who was an ulcer at one point. It now becomes a surgical wound because surgery was done on it. Okay, burns are another area. And this one, so M1200, this is where we start really digging into your reimbursement and where your appropriate documentation, A, for an accurate MDS, B, to help with the care plan, and C, to make sure that you're categorizing appropriately into the correct RUG score and receiving the reimbursement that's appropriate for the services you're delivering to the resident. So just go through these briefly. This is section M1200 on the MDS, and the areas that will actually trigger as ulcer treatments, what the MDS needs to have ulcers be coded into the clinical categories that we're going to talk about, the special care categories. You have to have at least 2 of these present, and it looks at A, B, C, D, E, G, and H. All right, so just go through those. If you do code a pressure-reducing device for chair or bed together, just note that's only going to count as one area. As far as the RUG calculator, it's not going to allow those two to be 2 separate skin treatments. And as I mentioned, you do need 2 separate skin treatments to track this information. Turning and repositioning programs, you want to make sure it's a true program. Right, and then we've got nutrition and hydration interventions. I'm actually going to progress to the next slide, and we can look at this. A few things that, for pressure-relieving devices, egg crate cushions of any type do not include, and that was something CMS clarified many years ago, that egg crates do not count as pressure-relieving devices. They don't see them as a useful tool to help in prevention. There's also the infection control issues that come along with using egg crates as well. Donut or ring devices and chairs are not focused as being pressure-relieving. Okay, and the turning repositioning program, this one I find quite commonly coded incorrectly as I'm auditing, and it's specific approaches for resident's position and realigning the body. The program should specify intervention and frequency. So you do need to be able to justify that these are specific approaches for the resident, rather than just a standard Q2 hour turning schedule for your residents. You do need to be able to document it and show that it's appropriate. Let's call it a program. It's got to be documented. You need to have follow-up to that too. And generally, what I mean by follow-up is just a quick quarterly note, or even right on your care plan, if you do have a comment section, to just address that this resident in particular, we turn at 8 a.m., 10, 12, that the program's working. There's been no skin breakdown. Okay. So a couple other things, just nutrition and hydration is also looking at the fact what codes under that are high-calorie diets with added supplements to prevent skin breakdown, and then high-protein supplements for wound healing. What I do see missed quite a bit is the prevention of skin breakdown. Most folks catch this when there's actually an actual wound, but if there are specific interventions in place, like the high-calorie snacks that are for skin breakdown prevention versus weight gain, that type of thing, and obviously it may serve a dual purpose, but you want to make sure you've got that clearly documented by a clinician, either a staff nurse or the dietitian, that they're able to separate this out and make it very clear that this resident is on, maybe it's a high-protein powder that they're on for skin prevention because they have a history or they're very, very high risk for skin breakdown. Okay, so the resource utilization groupers, as I mentioned early on, this is a national call. And we've got folks represented from many states, and many of you are still sitting on the RUG 3 system. As far as what gets captured on the MDS, it's really not all that different. It may just classify you into a different RUG category, where the RUG 3 system has special care, just one special care category. The SS is where they'll start, and RUG 4 has a couple different levels, right? And that's what we're going to look at. We're going to focus specifically on RUG 4 here. And you kind of see where you qualify, and it falls into the special care low category. All right, so just a few other key points as we're looking at the reimbursement side of this, as well as your expense side. Wound care, as many of you know, is very costly and it's very labor intensive. So you want to make sure that you're getting appropriate payment for services, and that's what we want to look at. Wound care can certainly take a lot of nursing time. May involve multiple staff members to get a dressing changed if it's a resident that, let's say it's on their coccyx and they have no ability to hold themselves over. You may need another staff member. And CMS is well aware of that, which is why they created the RUG system and classified this into a special care law, which is a higher pay nursing category all in all. Inappropriate coding can result in a loss of over $100 a day. And that's just really driving off a Medicare Part A resident, one MDS where somebody was coded incorrectly. You may not capture the appropriate payment category. And to show you these are the indicators that hit special care low for RUG 4. And what we're looking at here really is the fact that I bolded what's going to really affect your quality, your RUG reimbursement. And looking specifically at ulcers, it's 2 or more of any stage 2 ulcer, or 1 or more stage 3 or stage 4. 2 or more venous and arterial ulcers, also very important. In light of time today, I did extract some of the information on venous and arterial ulcers, but again, if it's something you want more information and guidance, you can look at your RAI manual as well as going to the CMS website under their MDS 3.0 link and pulling the training slides off. There's quite a few pictures that I believe are very helpful for venous and arterial ulcers. So as we go along here, it could also be 1 stage 2 ulcer and 1 venous or arterial ulcer, and with 2 or more skin treatments. Again, that's what we were talking about earlier, those areas that qualify in M1200 as skin treatments. And just one more time, that the pressure relieving device, the bed and chair, only counts as 1 if you've got them both checked. Okay, the other things in this category are foot infection, diabetic foot ulcers, and open lesions of foot with treatment as far as skin conditions. So one other thing is, this is different RUG 3 to RUG 4. With RUG 4, if your ADL category is 2, or if it's a 0 or a 1 for a highly independent resident, or they're supervised, maybe limited assist for an item, then they will actually default out of this category. We probably won't see a lot of that if you're looking at true pressure ulcers. You may certainly have that with a diabetic foot ulcer, but generally a resident who's got some form of true pressure ulcer requires much more assistance with their ADLs that would code a 2 or higher under the ADL index. Okay? But if it is somebody who codes a 0 or 1 with their 4 late loss ADLs, which are bed mobility, eating, toilet use, and transfer, then that resident will actually default down to the clinically complex category. Okay, and that's specific to RUG 4. Under the RUG 3 method, it allows the resident to sit in special care with a lower ADL score than the threshold. Okay, so I just want to spend a moment here talking about the quality measures. Whether you're aware or not, CMS posted on September 29th the latest draft by RTI, which was the organization that took on putting all the quality measures together. And that information is now available on the CMS website as well. You can go in there, and there's a search in the upper right-hand side, and you can just type in quality measures. We can probably get the link out to you folks as well if you're interested in it. And so just to, I say that because there was another report that went up in May of 2011 that I found some people working off of. And just as a reminder that this was updated, and there were quite a few changes to it, so don't rely on that May report. You want to make sure you go back and pull the September report. Okay? Quality measures will be updated via 5-star quality rating system on Nursing Home Compare beginning April 1st. Right? As many of you know, the quality measure portion of 5-star has been frozen since last April. It still sits on the Nursing Home Compare website. And, unfortunately, it was good for some folks and not good for others. We're kind of hoping that that was going to be taken off completely, but some of you may have had a bad quarter with your quality measures because of some internal issues or resident types that you had admitted didn't really have the ability to fix that, which you will going forward when the quality measures go live again. But knowing that the quality measures are going live April 1st is we're already in the sample period with MDSs, and especially the MDSs that they're going to use for a point of comparison. Quality measures, it drives off of 2 MDSs, a lot of them, and it's going to look at MDSs that we are currently doing. So now is as good a time as any to really look at your internal processes and make sure that everything's accurate before this all goes fully live and is publicly reported, and now that you've got a chance to make some internal changes. Measures also are a great tool for surveyors. It helps them create their audit sample. Those of you who are in states that are quality indicator surveys, you've got much more risk here. Surveyors, as quality measures and 5-star start going live, so does all the quality measure data of the surveyors. So they're going to start like they did prior to quality measures going dark. They're able to create a very large percentage, most of their full percentage of who they're going to audit and what they're going to look at, identifying their issues. So the quality measures specifically are going to have 2 different measures. There's going to be a short stay and a long stay. And the short stay measure is the percent of residents with pressure ulcers that are new or worsened. And the long stay is a percentage of high-risk residents with pressure ulcers. Okay. This is actually great news, I think, for a lot of us that are on here. I know one of my personal frustrations with the prior quality measure system was the fact that you really you were penalized if you didn't heal or improve an ulcer. And the short stay measure generally works off your 5 and 14-day MDS. So just to kind of keep that in mind and make sure that you're aware this is actually good for us, that it's now going to track new or worsened pressure ulcers. So something going from a stage 2 to a stage 3, or the presence of a new stage 2, you're not going to have that where you need to heal it up or even improve it in a matter of several days going from your assessment reference dates. So I think that, like I said, that is pretty good news for the industry. And the numerator for this is it looks at short stay residents. And a short stay in CMS's eyes, somebody who's in there for under 100 days, it then generally compares the 5 to the 14-day assessment. And this part is specifically driven off of M800, where you're coding a worsening and pressure ulcer. And as I mentioned earlier, remember, very important that this worsening pressure ulcer via MDS is looking for changes in stages, not necessarily length times width. Right, so you're looking for that change, progressing to a higher level. Okay, just a covariate. There's the new quality measures only 3 of them use covariates, and what I've listed here, without getting into a lot of detail, is it's a risk. Covariates are risks that are built into quality measures that will exclude, or not necessarily exclude, but it will change the curve a little bit for your facility. If you're a facility that has a high level of diabetes or PVD, that type of thing, where they're going to expect, there'll be a different risk indicator that's built into your quality measures. Okay, your long stay pressure ulcers. This captures any of your long stay residents. So as I mentioned, a long stay in CMS's eyes, anybody who's been in your facility for 100 days or more. Okay, and it's looking for stage 2, 3, and 4 pressure ulcers. Numerator is, it's looking, as I mentioned, for everybody who's high risk. It's looking at any stage 2, 3, or 4 that is coded in M300 as we went through before. And those numbers there, that 1 through 9, that is just the number of total ulcers. Just a couple other indicators here outside of M300 are with your ICD-9 coding, I8000. The 3 codes listed here, 707.22, 707.23, and .24, will also drive that there's presence of an ulcer. So just be very cautious, because I've seen folks that they resolve the ulcer in M300, but they leave it under I8000. So you want to make sure that that gets extracted out of I8000 if you have healed your ulcers. Okay. Oh, sorry about that. My screen froze for a minute, and I hopped a couple there. But okay, so just a few more things before I wrap this up on my side is PayforPerformance, and just to kind of let you know where we're at with that is there's still a project going on in 3 different states right now. It's a 3-year project that started July 1st. We are actually expecting a report to Congress. It was supposed to be delivered to Congress on October 1st of this year, just a preliminary report of how it's going in these 3 states listed, New York, Wisconsin, and Arizona. And the whole value-based purchasing is based upon quality measures, and it's looking at staffing, appropriate hospitalizations, outcome measures from the MDS, survey deficiencies. So what the Pay-for-Performance is going to look at, it's looking at your overall scores. So if you've got one area that's not in good shape, it could prevent payment for you. And we don't know what the final report's going to look like, or how the final Pay-for-Performance is going to be rolled out. But what they're really talking about is anybody who's lower than 80 percentile coming up with these quality measures is going to end up having some payment held back. Right? And those of you who score between 80 or 90 will get full payment, and they're going to add additional bonus payments for people that can maintain over 90%. Right? Just one other thing related to this is your appropriate hospitalizations. Again, skin is very important. You want to make sure you're assessing residents appropriately. We don't want folks going out to the hospital, because they had an infected wound or something like that, something that could have been avoided in our facility. And I'm sure as many of you are feeling the pain already, the hospitals are getting much tighter on this because of the fact that they're in a pay-for-performance demonstration. They're much closer to going live with full pay-for-performance. And one of the heavy hitters for both of us is inappropriate hospitalizations. Okay, so, the expense management side, I've seen a lot of facilities that do a great job with reimbursements, getting paid appropriately, understand their wound products, what's available, but they don't monitor their expenses very well. So that's something you need to look at very closely. Make sure you have a formulary and that your staff are aware of the formulary and you're consistent, again, with your wound products. Technology is an aid. This is a big initiative with CMS. They're looking for us to be 100% electronic in the next year or two. So you want to make sure if you can adapt technology at this point, it's a great time to do it. It allows much tighter management, much closer tracking of wounds, right? And as I mentioned, pricing and product availability. Again, you want to work with your vendors, shop vendors if you need to get better prices. All right, and the last comment I really have for expense management is make sure you're involving the clinical team. And I know it's mostly clinicians on this call, but you want to make sure somebody on the clinical team is looking at your bills and the expenses on a monthly basis. So your clinical team, who's actually out there caring for the residents, knows what kind of costs are going into caring for this person. A lot of times the bills will come into finance and there's no clinical tie-in. You just want to be double checking that. Okay. All right. At this point, we're going to open it up for questions. Deb's going to take back over. I want to thank you all very much for your time today. I do appreciate it. What's listed on this slide right now is my email address and my phone number. If you have any questions or follow-up, if you're a little bashful to ask in a public forum, you want to do it via email, please feel free, or you can call the number listed there too. Certainly want to be able to clarify anything if we caused any confusion with anybody out there, or if you heard something a little different from what you've been doing. So again, thank you. I appreciate it. Now, I will be sitting online here. I'm going to turn it over to Deb in case some questions do come up.
Thank you, Dave, for that great presentation. So as you can see on your screen here, if you have any follow-up questions or would like to reach out to Dave, he welcomes that, and his contact information is here. So big thanks to Dave's firm, Post-Acute Consulting, for hosting today's webinar. In addition, another host of our webinar today is Wound Rounds, and Wound Rounds is a point-of-care wound management and prevention solution. And Wound Rounds underwrote today's webinar. If you think about the sweeping changes that are going through our industry right now, and when CMS changed the minimum data set this past October to add more assessments for skilled nursing facilities, effectively what they've done is created a situation where residents now have the opportunity to be evaluated every 7 days, and that someone had done the calculations, and this can actually increase your assessments by 10 to 25%. And now with the changes that we're looking at for 2012, there's potential for your assessments to go up in workload by 40%. So when you ask yourselves, how are we going to get more done with the same or fewer resources, then factoring in an 11% cut, you have to ask yourself, how are we going to accomplish all this? And Wound Rounds is positioned here to address that question very well, because they automate MDS 3.0 reporting. And as you can see here, there's opportunity for saving in user time and also in reduction of wounds and wound care costs. So big thanks to Wound Rounds for underwriting today's webinar. I'd like to let you know that there's another one coming up. There's another Wound Rounds webinar scheduled for next month, December 8th, on the subject of technology for improved wound management. And today's attendees will automatically get an invite for that, in addition to a link from today's recorded webinar. So you'll get an opportunity to see the slides and audio from today's webinar as well. At this juncture, what I'd like to do is turn the floor over to questions and see what kind of questions you have all been submitting throughout this webinar. And if we have any questions here, we'd like to see them now. Here's one that come up. And hey, Dave, I think this is a great question for you. So we saw in your short stay residence that there's problems if your wounds don't progress. But what about the converse? What if your wounds heal in less than 90 days? Does that positively impact your reimbursement?
Okay, yeah, that's a great question. As far as the wound healing in less than 90 days, there's a couple things. I mean, first, on the expense side, that's certainly going to be very beneficial because you won't have the expense of your staff time changing the wounds and the supplies. But the way it's going to work, as it did for those of you involved with quality measures in the 5-star prior, it's going to update on a quarterly basis. So again, it will be very important. So probably the best answer to that is yes. Because when you do your following MDS from the one that had the wound there, it's going to show that you had an improvement. And, it may just be something as you're looking at your assessment reference dates and when the quality measure updates are going to happen, that you focus in a little bit. Maybe doing an MDS a little bit early. There's never any harm to doing it early to be able to, I wouldn't recommend doing it too early, but if you do it a little bit ahead of time, you may be able to capture that for the following quarter when PayforPerformance is fully in.
Thank you, Dave, for that answer. Looking now to see if we have any more questions coming in. Here's another one, Dave, for you. What % of wound supplies are reimbursable?
All right. Well, that's an ever-changing question. It's one that I would really recommend, you folks work with your current vendors. If who's ever providing you with your wound supplies, many of the companies offer, there are some that in a Part A stay, you're obviously, that's an all-inclusive charge for a Medicare Part A resident. So that's a cost that you're going to incur without any reimbursement. Well, you will. I mean, it's reimbursed through the Rokes system, and that's built in, and it's the importance, again, of making sure you get the appropriate category. As far as Part B, because that changes so much, it's really it's a whole nother day's webinar. I'd really recommend that you work with your your vendors and see what is actually chargeable to Part B. And it's a lot of paperwork, and I think that's why I fall back on your vendors. Is they're very efficient at doing it, and they know what needs to be done. So work with those folks.
Scott, Dave, thank you so much for today's webinar and presentation. And with that, I'm going to wrap up this webinar and thank everyone for their participation today, reminding you that you'll get a copy of the recorded webinar via link, and you also get an invitation for the next webinar that is scheduled for technology for improving wound care. Thanks to Wound Rounds and to Post-Acute Consulting for hosting today, and I'll sign off now. I'm Deborah Kurtz. Thanks much.